everyone. It is now 11:30 and I think we'll go ahead and get started. My name is Liz Loggeson and I'm the training director for the UCLA Tarjan Center, which, as many of you know, is our University Center for Excellence in Developmental Disabilities. And on behalf of the Tarjan Center and our co-sponsors, the UCLA Center for Autism Research and Treatment and the UCLA Intellectual and Developmental Disabilities Research Center, I'd like to begin by welcoming you all to our first lecture of the 2020-21 lecture series. A couple of housekeeping items before we begin. This lecture will be held from 11:30 to 12:30 with a 5 to 10 minute Q&A at the end of the hour. So if you have any questions for our speaker, feel free to send them through the Q&A link, which can be found on your Zoom toolbar. Also, you will be provided with a link to complete the speaker evaluation at the end of this presentation, so we hope that you'll take a few moments to complete this survey. And without further ado, it is my pleasure to welcome our distinguished speaker, Dr. Raina Factor. Dr. Factor is currently a postdoctoral clinical psychology fellow in the David Geffen School of Medicine at UCLA, with joint appointments in the Child and Adult Neurodevelopmental Clinic, also known as the CAN Clinic, and the Program for the Education and Enrichment of Relational Skills, also known as the PEERS Clinic. By way of background, Dr. Factor has been working with individuals with autism spectrum disorder for over 17 years. She completed her undergraduate degree at Emory University, and after graduating there, worked as a research associate in the Kazri lab at UCLA for 2 years, focusing on the JASPER intervention developed at UCLA by our very own Dr. Connie Kazri. Dr. Factor then completed her master's and PhD in clinical psychology at Virginia Tech under the mentorship of Dr. Angela Scarpa before coming back to UCLA to complete a predoctoral clinical internship in autism and neurodevelopmental disabilities at the Semel Institute for Neuroscience and Human Behavior. Dr. Factor's research interests focus on social and emotional development in children with autism, with a particular emphasis on the impact of peers, parents, and family members as mechanisms of change in evidence-based interventions. And I currently have the pleasure of working with Dr. Factor in collaboration with Dr. Amanda Goldsrud on a randomized controlled trial testing the efficacy of a college to career transition program for young adults with autism, known as Peers for Careers. And she has absolutely distinguished herself as a superstar among our clinical team. So it's a real pleasure to work with her. Dr. Factor is truly exceptional in that she has expertise working not only with individuals and adults with autism, but really across the lifespan from preschool to adulthood. And so today we are very fortunate to learn more about her research, examining caregiver-child relationships and family functioning in evidence-based social skills training for young children with autism. So please welcome me or join me in welcoming Dr. Raina Factor.
Thank you so much, Dr. Loggeson, for that wonderful introduction. Hello, everyone. I am Raina Factor. As Dr. Loggeson mentioned, I am currently a postdoctoral clinical fellow with joint appointments in the PEERS Clinic and the CAN Clinic. I would like to thank the Tarjan Center for allowing me to present my research to you, along with the UCLA Center for Autism Research and Treatment. A couple notes. I will be presenting on the Peers for Preschoolers program. I would like to make note that this research was actually conducted outside of UCLA, that was originally created at UCLA. And I will also be using the term caregiver interchangeably with the term parent, grandparents, really considering anyone who looks after a child. So with that, I will get started if this works. There we go. Right. And so just to give a brief outline of what I will be talking about today. So we'll start with a review of the literature. So going over the social impairments in ASD, some of the interventions, caregiver and family involvement, and then talking more about the current study that I'm focusing on today, and especially talking about future directions based on this work. So starting with a review of the literature, it is well known that social difficulties are one of the core components for children with ASD and individuals with ASD. And often social impairments are present early on, and they're likely to worsen over time. Other core difficulties related to ASD include restricted interest, rigidity. We also see lack of awareness of how their actions sometimes influence other people or might affect other people. In terms of social competence, we see a decreased ability to make and maintain friendships. And this is not saying that all individuals with ASD lack social motivation. Some of them are highly socially motivated and they report that they feel lonely. They want friends. They just don't always have the skills and the knowledge for how to make and maintain friendships. So for example, they lack the ability to initiate or maintain social interactions. They don't possess that empathy. They have a difficulty interpreting verbal or nonverbal communication, so much so that, for example, if someone turns away from them, they don't always understand that that means that that person might not be interested in what they're saying. And again, they have difficulty understanding others' thoughts or emotions. Sometimes they have difficulty considering that other people might find topics that are interesting, that are different from their own interests. Oftentimes, these early social reciprocity deficits are present early on, even pre-verbally, in individuals who are later diagnosed with ASD. So in infants, we often see lack of social smiling, lack of eye contact, lack of orienting or facial processing. Often we think of playing games with infants or toddlers like peekaboo or tickling games, and they might not always respond to that. When an adult smiles, they might not smile back. Also, we see that children with ASD spend less time interacting with peers. They have lower quality exchanges. They remain further apart physically, though right now we're all kind of maintaining that social distance, even if that means that we are staying in our houses and communicating virtually, much like we're doing today. And they spend more time engaged in non-goal directed activities. So for example, during recess, they might not be playing with a group of children and building a castle together. They might be looking at the blocks and lining them up. So there are a number of social skills interventions that specifically target these social skills, especially for young children with ASD. Social communication is really a top target and a treatment target. And this really focuses on teaching them the skills to communicate their needs verbally, and we especially see this in minimally verbal, nonverbal individuals with ASD. Often a lot of social skills interventions are geared more towards adolescents or young adults because, again, programs for younger children are more focused on that communication. Oftentimes the gains are minimal and they're not maintained beyond treatment. And there are very few manualized interventions that are currently available, especially for young children with ASD. So thinking about caregiver involvement in interventions, there has been a shift recently from a professional-driven model to a more family-focused model of intervention. And that means that caregivers are trained to conduct these interventions, or they're taught the buzzwords, how to include these skills in their home environment. And this really helps with generalization of these skills. So for example, a child doesn't just use the skills that they learn for 1 hour when they're at their intervention session each week. They can use these skills at home because the parent is equipped and they know kind of what to do and say. There's also a bidirectional effect of ASD on the family system and on the caregiver, and this also impacts the child. So for example, caregivers are very highly involved in working with their child with ASD, it can be stressful on them. It can often lead to negative effects like poor mental health for the caregiver, which then negatively impacts how they may interact with their child. And this may negate any gains made by the child during a treatment program. So again, there's that bidirectional effect. And as I mentioned, this involvement of caregivers can help with generalization, especially with social skills, beyond a social skills group. So looking at kind of the larger system, so the caregiver and the child with ASD, they're part of a family. So this is really focusing on the family unit. So family systems theory is the idea that individuals cannot be examined in isolation. And this stems from systems theory, which looks at meaningful wholes that are maintained by the interaction of their parts. So again, it's that the individual with ASD and their caregiver, they're part of a larger family unit. So the way that they act or the gains that they make might influence the rest of the family. And just to indicate how important the family unit is, family conflict is often more predictive of ASD symptomatology than positive family or peer influences. So again, looking at the whole family is really critical. And the gains made by the child with ASD completing an intervention also needs to be compared to the effects on the family unit. So just to summarize these points, there are very few evidence-based interventions explicitly designed to address the development of social skills in preschool age children with ASD or young children. And there are few, if any, that appear to actively integrate caregivers into this intervention, which we know is very important. So this leads me to talk about the PEERS program. And so PEERS, the Program for the Education and Enrichment of Relational Skills, was originally developed here at UCLA in 2004 by Dr. Elizabeth Lageson, and she currently runs the PEERS Clinic. It's been translated into over a dozen languages. You can see the various manuals over to the side, and it's used in over 85 countries. I just participated in a PEERS certification training. I believe there were 300 people from 17 different countries. For some participants, it was the middle of the night for them, but they were so eager to learn these skills, especially because PEERS is one of the only evidence-based social skills programs and the only evidence-based social skills program for teens and adults with ASD and other social challenges. So it's really important for providers to learn these skills. And it's, in addition to it being used in a number of different countries kind of over the globe, there's also a school-based curriculum, and it also can be delivered individually. So there are a number of different programs: PEERS for preschoolers, which I'll be talking about today, PEERS for adolescents, and PEERS for young adults. And all of these focus on making and maintaining friendships, but they teach different skills that are developmentally appropriate. Also, another wonderful aspect of the PEERS program is that it teaches ecologically valid social skills. So that means that these are skills that are used by socially successful people. And they can really be generalized and used in multiple contexts. And so what we often tell people, parents, is that this is not a friendship matching group. It's really where our hope is that participants will learn these skills and then they can apply them to different contexts. We also have some research programs. So PEERS for Careers, which, as Dr. Lageson mentioned, I'm involved in that program, and that's working with young adults with ASD who have some college experience and are looking to transition to the workforce. PEERS for Dating, which is a topic of interest, especially after the wonderful Netflix series Love on the Spectrum, which Dr. Lageson is featured in. I highly recommend watching that if you haven't yet. And also PEERS L-DOPA, which includes a medication component as well. All right, so Peers for Preschoolers, which I'll talk a bit more about the specifics of the intervention, is a program that uses the Peers basics and has extended that program for individuals, younger individuals with ASD. An initial randomized controlled trial indicated benefits from P4P, such as increases in social skills and a reduction in ASD symptoms and problem behaviors that can affect the application of these social skills. So model of intervention has been suggested with two primary domains. So caregiver and family outcomes and child outcomes. And this takes a more holistic view, and it's been suggested that both of these domains should be consistently evaluated to assess the success of a treatment. And so this is kind of capturing all of the topics that I've discussed so far. So therefore, given this information, the study aimed to explore the P4P curriculum, examine social skills improvement in the child with ASD, caregiver efficacy or confidence in their knowledge in interacting with their child, the caregiver-child relationship and interaction skills over the course of treatment, and family functioning in the context of treatment. So just to quickly go over the different hypotheses, so they're all broken up into those three different domains that I discussed. So we predicted that there would be an increase in child's caregiver reported social skills, and these improvements will be maintained after treatment and at follow-up. And there will also be a decrease in ASD symptoms related to social functioning from entry or pre-treatment to post-treatment and maintained at follow-up. Considering caregiver efficacy and behavior, so caregivers will increase their knowledge of social skills, gain more confidence in working with their child, and explicitly kind of coaching them during these social interactions, improve the caregiver-child interactions in the domains of responsiveness, affect, achievement, and directiveness. And again, all of these are from entry or pre-treatment. We're hoping to see improvements at exit and maintained at follow-up, and improve in parenting styles, specifically in laxness, overreactivity, and verbosity. And again, these would be maintained after treatment. And I'll talk a bit more about how we measure those. And then finally, looking at family functioning, we predicted that household chaos will improve from entry or pre-treatment to exit post-treatment and maintained at follow-up. We know that chaos is part of a lot of families, but this is something that we specifically measured in terms of how chaotic or stressful is the household and the family unit. So this brings us to the method. So for this particular study, there were 15 children, and they were part of 4 different P4P groups. And again, I'll just mention that this study was conducted outside of UCLA, so we ran some groups in the greater Atlanta area and in Southwest Virginia. Children were between 4 to 7 years of age, and the mean age was around 5. Groups at UCLA are typically for individuals who are 4 to 6 years, but we extended that age range a bit. There were 11 boys and 4 girls, which is pretty representative of the ratio of ASD diagnoses, and especially at this age, there are more males that tend to be diagnosed with ASD as opposed to females. The group was about 66% white. We also have the age range for caregivers, and all children had an ASD diagnosis without intellectual impairment, so their IQ was greater than 70. Inclusion criteria included that an ASD diagnosis, that they were fluent in English, toilet trained, and they were able to tolerate a group setting. And exclusion criteria included an active medical problem, any severe mental health difficulties, physical aggression towards staff, adults or children, and medication change over treatment. So meaning that they were unable to maintain the medication that they were on at the start of treatment. So this is a consort design. I know it's a bit small, but you can just see we used a two-stage eligibility process. So we had an initial phone screen, then we did eligibility assessments, and eligible families were then invited to join the study. We began groups with 17 families and then ended with 15 families. And we only lost one family at follow-up, which is pretty exciting. So almost all of our families came in and filled out their follow-up paperwork, which isn't always the case. Of note, we did have a number of families who didn't fill out all of their exit paperwork. So you'll see that in some of the numbers reported. So to talk a bit more about the methods, we used a non-concurrent multiple baseline design. And this is a series of A/B replication, and this was specifically chosen to allow for rolling enrollment. So that means that we can continue enrolling as we're starting a group, and especially because we had an allotted amount of time. So we were trying to get as many groups in as possible. This is also appropriate for a smaller sample size, which we had predicted we would have. And there is a baseline period, which I'll discuss in the next slide and what that looked like. So that's a period before the treatment actually begins, where families complete a specific battery of measures at certain time points. As I mentioned, we did eligibility appointments, so pre-intervention assessments. They completed the 16-week P4P program. There were midpoint assessments, exit or post-intervention assessments, and then follow-up assessments, which were 4 to 6 weeks after treatment. So in terms of randomization, each group was randomized and considered an individual in this context. And they were randomized to a baseline condition. So these conditions were either 1.5, 2, or 2.5 weeks for a baseline period. And this was the time period before they began the P4P intervention. So during the baseline period, caregivers completed ratings of social skills, so through the social skills monitoring form, parenting style, which was rated through the parenting scale, and family functioning through the chaos scale. And they completed the measures every half week, which was the same consistency at which they completed the same measures for each session. So again, we completed all 16 sessions, but we did it 2 sessions per week, so it's over 8 weeks. And this just tells you how frequently they completed the forms. And each family received a packet after their eligibility appointments with this paperwork, and they were contacted when it was time for them to fill out these forms, and they turned in their baseline paperwork at the start of the intervention. So to talk a bit more about the measures that were used, so to measure social skills, we looked at the social skills monitoring form, and this is a form that is 28 questions. 18 of them capture social skills, and we really wanted to capture kind of caregivers' confidence in the skills taught in P4P. We also looked at the social responsiveness scale, the second edition, the SRS2, which captures a number of different domains that are pertinent to social skills, and often we see these in ASD, and we can see different levels of how they score on this scale. We also use the social skills improvement system, the SSIS, which also captures social skills as well as problem behaviors, and the quality of play questionnaire, which looks at play dates, the frequency of play dates, and kind of the quality of those play dates. All right, so for our next hypotheses, we used the social skills monitoring form. And so this again, and there were just a couple questions on there that really captured caregiver stress and confidence. We also use the parental self-efficacy scale and the management of Asperger's syndrome. And so this really captured parental self-confidence or self-efficacy. We also use the maternal behavior rating scale. And this is an observational interaction task, and they're rated on 4 scales. So the achievement orientation scale, which looks at, and oh, I apologize, I'm having a bit of computer difficulties. So which looks at kind of how focused the parent is with the child's development, how much praise they use, the responsivity scale, so how responsive they are to the child's bids at what they suggest to play or how much they try to direct play, the affect and animation scale, so how much enjoyment do they show, how animated are they, and the directiveness scale. Oh, I think I already mentioned that. And then next we have the parenting scale. And so this really captured kind of the parenting style. And as I mentioned, those 3 different domains and also their overall style of parenting. Okay, and then finally, to look at family functioning, we looked at the chaos scale, and so this captures the amount of chaos or disorder kind of within a family. So that's the confusion, hubbub, and order scale. I love the name of that scale, and it really does stand for chaos. And we also measured fidelity of implementation because we were conducting these groups across different sites and using different group leaders. And so we wanted to make sure that we were administering the intervention at fidelity. And so we measured this across groups and for each session. And so this is a timeline of the measures. So you can kind of see when we applied each measure that I just spoke about. So some at pre-treatment, mid-treatment, the ones at each session, post-treatment, and the follow-up assessments as well. All right, so getting a bit more in depth about the P4P intervention. So again, this is a 16-session intervention. We met 2 times per week, so there were 2 sessions per week. So it was conducted over 8 weeks to fit into the allotted time frame. And the goal is really to teach these fundamental play and social skills in caregiver-assisted social skills groups. There are separate caregiver and child sessions, so they're each 60 minutes and they are occurring simultaneously in different rooms. And then there's a joint portion at the end for 30 minutes where there's parent coach play. And I'll talk a bit about what that looks like. So in the caregiver room, they focus more on, how the past week went, talking about didactic lessons, learning the same skills that the child's learning, and also discussing how they can social coach their child. In the child sessions, we teach didactic lessons, so the same skills that the parents are learning, but through live puppet shows that are developmentally appropriate. So we use puppets, which you'll see on the next slide, and then each child gets to practice using the skill, and we engage in behavioral rehearsals, so games where they can really practice the skills that we're teaching to reinforce those. And I'll also say in the child's group, again, to make it developmentally appropriate, we give them points and they earn prizes, and all the parents are in there when they pick their prizes each week. So it's pretty exciting and it makes it fun for them. For the joint portion, the last 30 minutes, that consists of parent coached play, where the parent coaches their child having an in-group play date, and they receive feedback from one of the members of the team. So they are being coached on how to coach their child, and that way they become more comfortable in working with their child and coaching them, and they can apply these skills in other contexts, in the playground, during a play date. And the last part that we include are homework assignments for this age group, the homework assignments are really for the parents. And they're not homework assignments that you would expect at school, like to write an essay on something or to do a specific number of math problems. They're really assignments like find an appropriate social group or source of friends for your child, schedule a play date, practice these skills. And so we check in on those each week in the parent group. So this is just an overview of kind of what all of these sessions cover. And I love that this intervention really builds on each session. So we start with listening to and following directions, which is so important if you have worked with young children or really with anyone. And then we go to sharing and giving a turn, don't be bossy, asking a friend to play, and we spend the last 2 sessions reviewing everything that we've learned. As you can see here, our wonderful puppets are featured. So these are the puppets that are used in the role plays. So we're not just talking at the children, telling them how to share and take turns. The puppets are really demonstrating these skills. So Kelly Cow is in a lot of role plays, Penny Pig, Franny Frog, and so they get to kind of know the puppets and are excited to practice the skills with them. All right, so quickly to talk about the analytic plan. So non-parametric Friedman tests were used, as well as post-hoc WILCOXON test to look at pre to post comparison and follow-up data, and also to look at the specific time points of where these changes might have occurred. Reliable change index was also, an RCI was also conducted, and this is looking at gains at more of an individual basis. And we were able to do this because of the size of our sample. We also use simulation modeling analysis. Again, this is appropriate for our smaller sample size, and this is where the baseline period comes into play. And we were able to look at changes and symptoms, and also look at the slopes of symptom change and the significance of these, also to assess for any temporal relationships or change in the variables that we were looking at. So now getting into the results. Okay, so looking at social skills. So we did find some significant changes in social skills. And again, this is across all 4 time points. So we saw these changes on the social skills monitoring form, in the social communication domain on the SRS, and also on the SCI. So this is kind of the total without the RRB, so the restricted repetitive behavior scale added to it, and on the SSIS in the social skills domain. And again, in looking at this table, the significant scores are highlighted in a lighter color, and they're also in black here. All right, so for these tests, the WILCOXON signed rank tests, I won't go over all of these, but as you can see, we found a number of significant differences, and we looked at kind of where these differences occurred. Some of them were from entry to exit, some of them were from midpoint to follow-up, and so this kind of allowed us to take a deeper look at where these changes that we were looking at really did occur. Okay, so in examining caregiver efficacy and behavior, we did find a difference in the AO, so that's the Achievement Orientation Scale on the MBRS, and again, that's the interaction task that was coded, and also in the Overreactivity Scale on the PS scale, that measure, and that, again, this is over all of the time points. So then in these analyses, we were looking at where these changes occurred. There were no significant changes in stress or confidence on the social skills monitoring form, though there was some increase in caregiver stress, though it was not significant. And again, this is one where these were really measured by 1 or 2 questions. And so that's something kind of in the future to look at that and examine caregiver stress in more detail. We did not use a scale that specifically looked at parenting stress because we felt that we were already giving parents a lot of forms to fill out, and so we didn't want to add another form. However, in the future, this might be something that we would include. As you can see on the other scales, which targeted caregiver efficacy and behavior, we did see differences at different time points. And then finally, looking at family functioning, so we did not find significant differences. This is in black ink. This was not a significant change on the chaos scale, and we did not see significant differences on the WILCOXON test. Now, this is a good thing that we didn't see an increase in chaos, family chaos, which sometimes occurs when caregivers are part of an intervention, especially because I know for some caregivers, they were in traffic and it took a while to get there. They had to commit to being at the sessions, but we didn't see a decrease in family chaos either. So looking at these RCI scores, and again, this is in terms of individual outcomes for social skills. So this is looking at the same 3 measures. I won't go over all of them, but as you can see, we did see in individuals, there were significant improvements from entry to exit and from entry to follow-up, and scores ranged from 7% of the sample to 80%. And you can see how many children that is, and those are in the parentheses. I will note the number at the bottom is a bit different for some of these time points, and that's based on the number of families that filled out the paperwork. It is interesting that 80% of children significantly improved from entry to follow-up on the QPQ, but when examining that overall, we did not see those significant changes. So that is something that I hope to further explore. All right, so looking at caregiver confidence and behavior. So we looked at these same measures. And you can again see that there were significant improvements in all of the domains, and there was a range. Some of them have only one caregiver that indicated improvement, and one of them on the in terms of caregiver self-efficacy, 7 caregivers indicated that they felt they improved in their self-confidence, especially in interacting with their child and in parenting. And you can also see on the NBRS, it's broken up into those domains that I mentioned on the interaction task. And then also on the PS scale, the parenting scale, you can also see we had 2 parents indicate that they felt that they improved, and then 1 who indicated that they improved from entry to follow-up. And then finally, looking at family functioning. So in terms of individual outcomes, 1 family suggested that they felt that there was an improvement in family functioning from entry to exit, and 2 families or caregivers suggested that there were changes in the level of family functioning or chaos from entry to follow-up. And so of note, when kind of examining the characteristics of these families, these were families where there was only 1 child. And also another one had both the child who participated in P4P as well as a younger child. So that's also something to take into consideration, kind of the makeups of the families and who all is involved in the family functioning and the family unit. So now we move to multivariate process analyses. And as you can see, we looked at these different slopes. And again, I won't go into this in too much detail, but these slopes on the side, or these lines, suggest the slope or the line to the left of the vertical line is the baseline period, and the line to the right is the treatment period. And the treatment period also captures the exit data and the follow-up data. And so what we hope to see, because all of our scores and our data were compared to these slopes through a number of kind of bootstrapping tasks or analyses. And so we hope to see an improvement at treatment. So we want to see an improvement in skills. So in looking at these, that's really slope 2 at the pictures, and I realize I'm pointing to the screen, but you guys probably can't see that. So that is slope 2 as well as slope 4. That's where we see the increase over treatment. And slope 5 also indicates an improvement during treatment with a small dip in the scores at the end of baseline and the beginning of treatment. Of note, again, I won't go through all of the analyses for this, and each group was really considered as an individual in looking at each of the 3 domains. But we did see that there were improvements, especially close to slope 2 and slope 4. Those were significant, which is what we want to see, which is very exciting, and especially in terms of social skills, we saw that across the groups. We were also able to look at mean level of changes between the baseline and treatment for those 3 scores and measures that caregivers completed during baseline, the baseline period, and also during each treatment session. So in group 3, we saw significant change on the SSM, so social skills. And in group 4, we saw a significant change on the PS, the parenting scale. I will note that some of the negative scores are actually more positive. So for example, on some of them, a decrease in some of these scores. So for example, a decrease in social skills difficulties actually means that they're improving on social skills. And the same is true for parenting scores and the parenting scale as well. The opposite is actually true for this particular social skills measure. So we do want to see higher scores to indicate that they are getting more successful at these skills. All right, and finally, so this table looked at process change through SMA for those 3 measures. And it's really looking at temporal change to see if there's a pattern where one variable changes before another. So you can see that they're all kind of broken up. So we're looking at the social skills, parenting, and chaos. And the number in parentheses, that's the lag time. And that means how many weeks does a change in one variable occur before a change in the next one. If the number in the parentheses is negative, that means that a change in variable 2, so the second one listed, occurs before variable 1. If the number is positive, then that means that a change in variable 1 occurs before a change in variable 2. And if the number is a 0, it means that they likely occurred at the same time. And so you can see here, and the significant changes are in a lighter color, and they also have the asterisks next to them, so you can see how significant they were. And of note, these are also with Bonferroni correction applied. You can see that often in terms of social skills, those were significant. And though no clear pattern emerged, there are clear relationships between these different domains, which is what this study really set out to look at, is a connection between social skills, caregiver, confidence, and also family dynamics. So getting to the discussion and future directions and conclusions. So to summarize, so this study really suggests that working on social skills is really key for early intervention and especially important for individuals with ASD who are at this young age. This also clarifies how caregiver involvement interventions is critical, and it really adds to outcomes, positive outcomes. And I will also note that there is a caregiver or social coaching component in all of the peers programs. This is the only one where there is an active caregiver participation where they receive that live coaching. We also see that many of the gains were maintained at follow-up, which is pretty exciting. Though we did not see any significant differences in family functioning. That's something that I believe we can explore in the future. And again, that is something that we just use one measure to look at family functioning. And use of both observational coding as well as caregiver reports adds to the robustness of these findings in this work. However, I do believe that there is room for more observational methods and more interaction tasks. So again, this adds to the feasibility. So it supports that this intervention is feasible to be administered across sites, as well as employing a training beforehand. All group leaders went through an intensive day-long training on the P4P curriculum, the structure of the groups. The UCLA Peers Clinic was kind enough to share the scripts with us, and so we had those and wanted to make sure that we were being consistent with how the groups are employed at UCLA. And the group leaders were also at various stages of training. So we had advanced doctoral students, post-bac students, students in clinical psychology. I think we had some students in public health. And all groups were supervised by an advanced graduate student as well as a licensed clinical psychologist. So again, this indicates that the groups are able to be administered by these different group leaders who have different levels of training. And these show very promising results to continue to offer P4P and the peers group to this younger age group, which is so in need of social skills services. So I'll just go through these pretty quickly since I know we're getting close to time and I want to leave some time for questions. So there were a number of gains in terms of social skills. As I mentioned, on the SRS, the SSIS, they were often maintained at follow-up. Also, we saw those on the RCI scores. We also saw those in the slopes on the SMA analyses, so it was slopes 2 and 4. We did see some slopes, slope 5, which showed an increase at baseline, a decrease, and then an increase again at treatment, which suggests that a booster session might be very helpful or beneficial. And what we are starting to do at UCLA is offer boot camps. And I think that this would be wonderful to also offer to P4P participants to kind of give a refresher of the skills that are taught in these groups. We did see change in parental self-efficacy such that they were more confident in their parenting abilities. And this generalizes to parenting overall in other domains, and perhaps because they spent this time with their child, they really believed in their ability to be a parent to their child. And especially even anecdotally, I saw this as they became more comfortable interacting with their child during the parent-coached play. And again, parents, caregivers are such an essential role in child improvement and also considering that bi-directional relationship. Right, I touched on in those. And so again, caregivers are so critical to intervention as they experience more confidence, also indicated through individual improvement on the RCI scores, and also in their parenting style as well. And then finally, looking at family functioning, though we did not find results that indicated change in family functioning through the chaos scale, results were largely stable throughout all time points. And two caregivers did indicate that family chaos did significantly improve based on the RCI score. This might suggest that other family members may need to be involved in an intervention, or more measures should be employed. Of note, we did not, this is a limitation, we did not take note of how many family members participated in the social coaching group. Some families had one parent, some had two, sometimes a grandparent came, and we didn't look at that in our analyses. And also including siblings, I think, is so important because they're also part of the family unit. So this suggests that caregiver training and this format may require less stress, and this allows parents or caregivers to still focus on their other children or their spouse. So I mentioned some of these limitations. So we did have a small sample size. However, we did select analyses that were appropriate for the sample size. This did limit us in that it might affect our ability to detect some interaction effects. This was a largely homogeneous sample in terms of race and gender, and so this is something to consider for future studies. As I mentioned, we did not record the family member who attended each session. We also didn't look at the gender of the parent, if it was a male or a female. And there has been research that indicates that mothers and fathers will respond differently to certain behaviors or situations. And so this is something definitely worth looking at. And we also mostly use caregiver report measures. Though we did use an observational measure, we can definitely use more in the future. So thinking about the future, so there definitely is a connection between social skills, caregiver efficacy and behavior, and family functioning. So continuing to look at the connection between these three domains, and really continuing to look at the whole family unit, in addition to specific child outcomes. And as I mentioned, involving siblings is so important, even if it means getting them to fill out a measure, if they're able to. I know we had some siblings sometimes who came to the groups, and so that would be a great thing to look at as well. So thinking about P4P in the time of the pandemic. So right now we know that providing P4P over telehealth for children who are 4 to 6 years of age with ASD is not really clinically viable. Can't get a 4-year-old to sit in front of a screen for 60 or 90 minutes. We have had success in the peers groups for adolescents, and results suggest that outcomes are the same for telehealth groups and in-person treatment delivery. And we also administer our young adult peers groups over telehealth. So we're working to develop a version of P4P that can be delivered virtually over telehealth with more of a focus on parent training, since parents are able or should be able to sit in front of a Zoom screen and really participate in those didactic lessons and show interactions of them coaching their child. We also plan to record the didactic puppet shows, so children will still learn these skills. So we are working on this currently, which is very exciting. And then finally, to wrap everything up, so again, this demonstrates the feasibility of implementing P4P or peers and adapting this for younger children with ASD. It's so important to examine both caregiver and child outcomes, as well as looking at the family unit. And this really addresses some of the core features and difficulties related to ASD, especially in terms of social skills for this age group. And I think doing some more longitudinal work would be very informative in seeing if intervening at this age helps with social skills as an individual matures. And future work will also kind of deepen our understanding in terms of intervention, looking at the child, caregiver, and family unit, and thinking about family functioning. So thank you to the Tarjan Center, the Peers Clinic. Contact information is there. A lot of this work was able to be conducted from support from the Virginia Tech Autism Clinic and Center for Autism Research. And that little panda is there because I was part of the Panda Lab at Virginia Tech, and it's raising its hand. So this is a great time to answer any questions.
Well, thank you so much, Dr. Factor, for that really interesting and informative lecture. We did save some time here at the end, about 5 to 10 minutes to do a little Q&A. And so if you do have questions, feel free to submit any questions via the Q&A feature of your toolbar on Zoom. Also wanted to thank you for joining us, and to please take a moment to complete a brief evaluation on this lecture. You'll find the link to that evaluation in the chat feature on your toolbar. So just to kind of start out the Q&A here, Dr. Factor, one of the earlier questions that we received is, did you see much peer support among parents during the program? And do you have a sense of the impact of this aspect of the program?
Absolutely. So parents providing support to parents?
That's sort of my understanding.
Parents? Okay, I just wanted to make sure I was answering that question. Absolutely. I think this is a great format where parents can really share their insight with other parents, especially with this age group, where oftentimes there are some families where the child has just been diagnosed with ASD, and other parents are able to share, this is a resource that we used, or this is how we shared this information with them. This is how we talk to the school. And so I think it's a great place for them to talk about what's going on. And I also saw, as the group continued, parents seemed to become more and more comfortable with sharing information and also providing that support to other parents, which was wonderful to see. And this has been across different groups, which is great.
Yeah. That's great. So another question is, are the tools that you mentioned readily available, and also has anything been done with teenagers?
Yes to teenagers. Yes, we are currently always running Peers for Adolescents. Those groups are absolutely available, and we are running telehealth groups. And that was some of the data that I talked about quickly at the end, that the preliminary results do suggest similar outcomes for in-person groups and telehealth groups, which is very exciting. And there are manuals for teenagers. And I've also been able to participate in those groups, which is a lot of fun. And again, the same thing is true for the social coaching piece. And it's great to see kind of how that the intervention really kind of shifts based on the age of the participants. So in that group, it's not so much about setting up play dates. A lot of the homework is on the teenagers are responsible for completing it. So for setting up their calls, and the parents really learn, okay, how do I act as a coach, help my child with these skills, not do everything for them. So there has been lots of work with teenagers, and we are currently working, and Dr. Lageson, you might have more to add to this, on making P4P resources available.
Yes, and we are actually currently working on that. So thank you for that plug, Raina. We're doing the final edits on the manual and hopefully sending those off to a publisher very, very soon. So more information on that to come. Another question that you have, Dr. Factor, is could you go over the ethnic breakdown of the families again, and were they all native English speakers, and did you have to do any translating and use interpreters?
That is a great question. So they were all native English speakers. So part of the inclusion criteria is that they speak English. Actually, no, I take that back. We had one family where English was not their first language, but they spoke it fluently. I believe that we had about 2/3 of our sample or our group who were white. We had, I believe, 6% who were Black. We had, I'm trying to, I know I have this breakdown. I'll get you the exact numbers. And we also had a number who were Asian American. Let me get you the exact number. And this was actually more diverse, I will say, than we expected, especially in Southwest Virginia, because we don't often have a very diverse sample. So we had 13% African American, 6% mixed race, 6% other race, and 6% Asian American or of Asian origin.
Okay, thank you for that. Another question that we had in the Q&A is, how sustainable are the benefits? And was there any measure done before and after to see if there's any increase in cognitive flexibility?
That's a great question. So we did not do the cognitive assessment at follow-up or at exit. And we didn't measure for that flexibility either. That's absolutely something that I hope to add in the future. There were sustainable outcomes in terms of social skills and the parenting confidence that we saw, but we didn't look at that. We can definitely add that though, and that's something we would like to explore.
Yeah, interesting to look at in the future. Another interesting question, what's the most challenging aspect of running these groups?
That is a great question. I would say sometimes, so it's very dependent on the group. From my experience, I think sometimes it's, if you have a very active group, it's getting them to sit down and listen. And sometimes we had groups where they became very good friends, which is very exciting. However, they would decide now is the perfect time to play Ring Around the Rosie, and they would want to do that when we were trying to work on teaching them some other skill. And so it was getting them to do that. And that's why there's such a high ratio of staff in each group to really support that and to support the children. I think after some weeks, they kind of get the sense of how the groups run, and also, you know, the stars and the prizes are very motivating. And I do this because we kept note of them on a dry erase board so they could see. I think it's very motivating, but I would say that's definitely the hardest part. And letting people know, okay, you need to intervene here or help that child sit down, those types of things.
All right, great. Another question that just came up is, did you have any caregivers or parents that were diagnosed with autism?
That is a great question. So none disclosed that. I did have one parent come to me and say, I think I might have autism. I would like to be tested. So no formal or previous diagnosis, but was interested in being diagnosed. And I really hope to measure autism traits in parents. That's the only situation or example that I can think of. There were some families who had 2 children on the spectrum.
Okay, thank you for that. I think this will be our final question. The final question is, can parents participate in this program without their children?
That is a great question. So in person, no. Through telehealth, so what we are thinking of doing, and this is in the works, is really working with parents primarily, and then they work with their children. So it will really be up to the parents to teach their child these skills. So they will be participating without their child, though we do want to use some of the same inclusion criteria. So it will be very interesting to see kind of what the outcomes look like when the kids aren't actively there.
All right. Well, thank you so much to Dr. Raina Factor for this really interesting conversation, and also just for sharing all of her really important and interesting research. We thank you all for attending the Tarjan Lecture Series. We want to encourage you to save the date for our next lecture series presentation, which will be held on Monday, November 16th at 11:30 a.m. Pacific Standard Time. In the meantime, if you have additional questions for Dr. Factor or want access to this information, feel free to contact us at the Tarjan Center. But once again, thank you so much, Dr. Factor. We really appreciate you sharing your important work.
Thank you so much for inviting me, and thank you all for attending. I so appreciate it.